So I chose this topic of edema because it is a very day-to-day problem. And every day when you sit in the OP, you see someone or other comes to you and tells you that my legs are swollen or there is some swelling around my eyelids. What to do? What's the major problem? And now everybody is so much worried about the renal disease. All that glitters is not gold. Even if you want to tell them, they don't get convinced. They think when something is swollen, it is only because of renal disease. Now let us see. So in the next 40 to 45 minutes, I will try to tell you what is the pathophysiology of edema. To understand the pathophysiology of edema, you should know what is the fluid distribution in the body. That will take us to the definition of edema. We will see how clinically you can classify edema and how will you clinically find a solution to this problem. What are the essential investigations you would like to do? And briefly, I'll touch upon the treatment. So this is the distribution of body water. This is my favorite topic. So no class passes without saying something about fluid and acid base because it's a passion for me. So if you take a 70 kg adult male, normal body water is around 60%. You see, that is in the 70 kg man, the total body water is 42 liters. So where is this 42 liters going to? Of this 42 liters, 3/4 goes into the intracellular compartment. The remaining 1/4 will go to the extracellular compartment. When we say the extracellular compartment, that is composed of the interstitial fluid, plasma, and the transcellular compartment. So to recapitulate, in a 60 kg man, 70 kg man, 60% of body weight is water. So that gives us a numerical value of 42 liters. Of this 42 liters, 2/3 goes to the intracellular compartment. We can't do much about it because it's inside the cell. The remaining 14 liters get distributed to the extracellular space. So what is the extracellular space composed of? Mainly, it is an intravascular compartment and the interstitium, and little goes transcellular. So when we talk about these 14 liters of extracellular fluid, 1/4 only is in the intravascular compartment. That is about 3 liters. The remaining liters, 10.5 liters, goes to the interstitial fluid. So fluid is distributed between the extracellular compartment and the intracellular compartment. Of the extracellular compartment, the main recipients are the interstitium and the intravascular. Only 1/4 of the extracellular fluid goes into the plasma. So when we talk about edema, we are talking about expansion of the interstitial fluid. So how would you define edema? So edema is defined as accumulation of fluid in the interstitial compartment. We said that the interstitial compartment consists of around 10.5 liters of water in a 70 kg adult. If for some reason this 10.5 becomes 12 or 14, that gives rise to a situation of edema. So this edema fluid can be simply water, as in a transudate, or it can contain protein and cells when we say it is an exudate. So edema is an accumulation of fluid in the interstitium, which is mainly composed of water and also protein and cells, depending on the cause of edema. Now, how will you say? Somebody comes and tells you I am edematous. So how will you elicit edema? The simple sign to elicit edema is press the skin above the lateral malleolus or medial malleolus in the shin of tibia. Normally, there is a displacement of fluid and gives you a pitting. That is called as a pitting edema. That is how you detect edema clinically in acute situations. So what are the sites you look for edema? In ambulant patients who are walking around and they say of edema, you have to look for edema in the feet, legs, and also around the eyelids. In a bedridden patient or a patient with on prolonged bed rest, you have to elicit edema in the buttocks, genitals, or posterior thigh. Depending on the site you lie, the fluid gravitates to that side, and that side becomes more edematous. Especially in women, that can give rise to unilateral swelling of the breast. When there is a lymphatic obstruction, the edema collects distal to the site of obstruction. So this is just to show you what are the body fluid compartments which I said, and how is the fluid lost from the body. As is seen, fluid is lost through the intestine. It is through the lungs, when you call this an insensible loss. It is through the kidneys as urine, and skin as insensible loss. So we generate fluid, we lose fluid. We generate fluid, we drink fluid, we lose fluid. So there is a fluid equilibrium. Whatever we take is lost. So the distribution remains constant, and usually we are not edematous. Who said all this? The whole process of filtration and accumulation of fluid is governed by Starling's law of physical forces. What is you would have learned in physiology from my Mbbs friends, you are just from physiology, you will remember what is Starling's law of physical forces. Starling's law states when there is a capillary and there is an interstitium in which it is enmeshed, there is a hydrostatic pressure in the capillary which is trying to push the fluid from the capillary into the interstitium, right? There's a fluid in the capillary. Fluid is blood. Blood contains plasma and RBC. Plasma contains water with protein and lipids. Of this water, hydrostatic pressure will try to push the fluid always from the capillary to the interstitium. We said there is a protein in the blood, predominantly is albumin, and we all know that the osmotic pressure is exerted by the albumin. When it is confined to one side of the compartment, we call it as an oncotic pressure. So there's an oncotic pressure contributed by albumin, which is trying to retain the fluid inside the capillary. So when I try to tell you something, you should be in a receiving mood. So the fluid is also trying to come out of the capillary, but the interstitium should be prepared to receive, But there are two forces there. One is a hydrostatic pressure inside the capillary, which is trying to retain the fluid in the capillary, and the albumin contributing the oncotic pressure, which is trying to keep the fluid inside the capillary. So that is why it's written, there is a hydrostatic pressure in the capillary minus the oncotic pressure in the capillary contributed by albumin. That is driving the fluid from the capillary to the interstitium. So when the fluid gets into the interstitium, as you proceed towards the end of the capillary, the interstitial pressure, hydrostatic pressure starts slowly building up. We know the capillaries are impermeable to albumin. So there is no oncotic pressure in the interstitium. So at the capillary end, the lymphatics will get the fluid from the interstitium back to the lymphatics and to the capillaries. So the net pressure which drives the fluid or keeps the fluid inside the capillary is the hydrostatic pressure in the capillary minus the oncotic pressure in the capillary is contributed by albumin minus hydrostatic pressure in the interstitium minus oncotic pressure in the interstitium. Though it is written in the interstitium, usually normal circumstances there is no albumin, so the oncotic pressure is 0. So the fluid usually comes out of the capillary into the interstitium, and from the interstitium it goes back to the lymphatics, and from lymphatics to the capillaries. That is how normally the fluid works. Now we will soon see when there is any condition that disturbs this equilibrium, the fluid stays in the interstitial compartment, giving rise to what is called as edema. So edema is nothing but increased collection of fluid in the interstitium. So increased capillary hydrostatic pressure is there. Decreased plasma oncotic pressure is there in the patients with hypoalbuminemia. If the capillary permeability is increased, or the lymphatics are obstructed, the fluid cannot leave the interstitium. So the interstitium expands and gives rise to edema. Hope it is clear. Now, what happens when the hydrostatic pressure is increased in capillaries? When there is a shift of fluid from the capillary to the interstitial space, we know naturally the fluid inside the blood vessel is decreased. That is called as intravascular volume depletion, which we usually say is hypovolemia. When there is hypovolemia, there are compensatory mechanisms that come into play, which will activate the renin-angiotensin mechanism. Renin is secreted by the juxtaglomerular cells of the kidney, angiotensin again by the pulmonary endothelial cell. Aldosterone, you all know, is by the zona glomerulus of the adrenal cortex. So it activates the renin-angiotensin-aldosterone system along with vasopressin, which leads to sodium water retention to compensate for the shift of fluid from the vessel into interstitial space. So the fluid starts going back to the vessel, and if you don't restrict your salt, there is an excess accumulation of sodium, which also retains water along with sodium and gives rise to edema. So this is how edema occurs in conditions where there is an increased hydrostatic pressure. To say that again, when there is a hydrostatic pressure increase, fluid leaves the vascular space into interstitium. When there is a deficit of volume in the intravascular space, the renin-angiotensin-aldosterone axis is activated, which retains sodium and water. It also activates the vasopressin system, which retains free water. So there is an excessive accumulation of sodium and water inside the vessel, which produces edema. So that is one cause for edema. The second common cause of edema is, we said, the Starling's law states that oncotic pressure contributed by albumin is mainly responsible for keeping the fluid inside the capillary. So when there is a reduction in albumin, there is a reduction in oncotic pressure. So there is a reduction in the movement of fluid from the interstitium into the capillaries. That can also contribute to edema. So let us see what are the conditions that can produce hypoalbuminemia. When we did our house agency, there is a separate ward in SAT hospital, which is our pediatric hospital, called Kwashiorkor ward. So children came there with protein calorie malnutrition, which is currently the name for a kwashiorkor. And they are all edematous, skin exfoliated, sparse hair, with all evidence of malnutrition. Nowadays, it has disappeared because of the governmental policies and so many charity organizations. Enough protein is given to the children. So nobody starves, if I remember right, or if I say right. So there is a decreased intake, there is a malnutrition, which is a disappearing entity now. The second common cause we encounter in our practice is loss of protein in the urine. That is nephrotic syndrome. When there is a massive loss of protein in the urine, more than 3.5 gram by definition in 24 hours per 1.73 meter square. Nephrotic syndrome is defined as loss of protein more than 3.5 gram per 1.73 meter square in 24 hours, or 50 milligram per kg, 50 milligram per kg in children. So there is a loss of protein in the urine. This leads to loss of protein in serum. So there is decreased albumin that produces decreased oncotic pressure. Fluid stays in the interstitium, gives rise to edema. Because the loose areolar tissue around the eyelids have a low hydrostatic pressure in the interstitium, in nephrotic syndrome, fluid usually collects around the eyelids. It is more commonly seen in the morning. The most common cause of edema we see, important cause we see, is nephrotic syndrome, which is followed by cirrhosis liver. We all know that liver is the site of synthesis for albumin. So when there is failure of the liver to synthesize albumin, the liver disease more than 21 days duration. There is decreased albumin in the serum, so decreased oncotic pressure. So more fluid stays in the interstitium, gives rise to edema. Not but the least important is a protein-using entropy. Gastroenterologists would say that's the most common thing. Crohn's disease, ulcerative colitis are common cause of malabsorption syndrome. There are other causes for chronic diarrhea as well. All this diarrheal loss will contain protein. So when there is no protein absorption taking place, liver cannot synthesize albumin. Again, there is a loss of reduction in the albumin. So reduction of oncotic pressure, which can produce fluid collection in the interstitium, giving rise to edema. So the two important causes for edema are increased hydrostatic pressure in the capillaries and decreased or decreased oncotic pressure in the capillaries due to low albumin. So there are other causes of edema as well. You all know that somebody consumes drug or some fish, they comes to you or the OP and they say, or the ENT people usually, there's a difficulty in swallowing, there is a swelling around the eyelids, that if you don't correct it or treat it, they can produce laryngeal edema and sudden respiratory arrest. This is what is called as angioedema. So what is the trigger for angioedema? There is a toxin or inflammatory mediator released, which produces damage to the capillary walls. So normally the capillary walls, which are not permeable to fluid to a large extent, develop increased permeability and the fluid transutes into interstitium. So it can produce edema of eyelids, it can produce difficulty in swallowing, and if not treated, the fatal complication that can occur is a laryngeal edema, stridor, and sudden respiratory arrest. So whenever you prescribe a drug, you should always ask for drug allergy. And these days, we get so many cases of shawarma producing death. I do not know. I don't eat shawarma as well. But I am told that shawarma releases a toxin because it is a prolonged storage of meat. And that toxin probably produces inflammatory damage to the capillary wall. And that leads to loss of many precious lives. If you come across angioedema, the immediate treatment should be corticosteroids and adrenaline if there is a reduction in blood pressure. So that is angioedema. Now let us see what is a focal edema. Focal edema is whenever there is an inflammation. There are so many mediators that's released, which include histamine, leukotrienes, and prostaglandins, and also complement-mediated factors, which produces locally and increase the capillary permeability, and the fluid collects there and produces focal edema. This is what happens in cellulitis. So if you see somebody with cellulitis, the cause may be the inflammatory mediators released by infection. Again, another common cause or pathophysiology for edema is a lymphatic obstruction. Because I said, as I started saying in the early slides, when the fluid reaches the capillary end of the capillaries, fluid is absorbed back to the lymphatics and then into the capillaries. So if there is a block in the lymphatics, this cannot happen. So the fluid will collect distal to the site of obstruction, giving rise to local edema. Now let us see a few cases and see how we approach the problem. This case scenario is a 30-year-old lady who attends OP for complaints of swelling. So what would be the first question you would like to ask her? Is it a symmetric swelling or asymmetric swelling? She says, I am swollen only of my right lower lip. I don't have swelling anywhere else in the body. That means it is an asymmetric swelling, meaning there is a local cause contributing to edema. Now, what are the causes of asymmetric edema? It can be inflammation leading to cellulitis. We all know that 4 cardinal signs of inflammation are calor, rubor, tumor, and rubor. That is, rise in temperature, redness, tenderness, and swelling. So that is what is called as cellulitis, and that can produce a local swelling. If there is a block, the veins that drain the fluid, as in deep vein thrombosis, it can also produce local swelling. As we said earlier, the lymphatic obstruction can also produce asymmetric edema. So the 3 important major causes for asymmetric edema are inflammation, venous obstruction, and lymphatic obstruction. Now, next what you have to see, is it a pitting edema or a non-pitting edema? So how do you elicit pitting? As I said earlier, you just press for 30 seconds above the lateral malleolus in the shin of tibia. If there is a displacement of fluid, it is called as a pitting edema. If there is no displacement of fluid, it is called as a non-pitting edema. The whole limb is swollen, but there is no pit that is appeared due to a pinching. Okay, so what does this mean? If it is pitting, it is a new onset edema. If it is non-pitting, it is a chronic edema. So when you come across edema, you have to see whether it is a pitting edema or a non-pitting edema. Does this edema confined to a local area, or is it a symmetric generalized involvement? Now, this lady who attends OP for edema says there is no pain. It is associated pain, redness, or fever. She said yes. So probably it is cellulitis, that inflammation of the skin. What are the most common cause for cellulitis? In diabetic patients, it is staphylococcus. In endemic areas, probably filarial lymphangitis producing edema unilaterally, focally. So whenever there is fever, redness, pain, and swelling, 4 cardinal signs of inflammation, you should search vigilantly for infection. So what are the investigations you would like to do? A complete blood count, which includes total count, differential count, platelet count, and CRP and a erythrocyte sedimentation rate. Pus culture, if there is an oozing from the site, you have to take pus for culture. So the appropriate antibiotic can be chosen. The treatment of cellulitis is antibiotics. And once you treat and cure the cellulitis, the edema would disappear. If there is no history of pain, redness, or fever, which this lady had, what are the other things you would like to ask in the history? Ask for history of recent surgery, prolonged bedridden state, history of recent surgery, other thrombogenic conditions like APLA syndrome. If any of the above is present, you should think it is probably a deep vein thrombosis. So how do you confirm a deep vein thrombosis? You can do an ultrasonogram, but confirmed by a Doppler of femoral vein, the lower limb is swollen. Why should you identify this condition? If you don't identify deep vein thrombosis, and if the patient continues to be ambulant, the simple DVT can lead to a fatal pulmonary embolism. During the COVID endemic, you all would have seen D-dimer was a routine investigation. Earlier, we never used to do D-dimer as a part of our infection workup. D-dimer is done just to find out whether this person has a thrombotic tendency. If there is D-dimer more than 1,000, usually they were started on the new set of anticoagulants, like the bond vitamin K anticoagulants, apixaban, etc. We are not going to the details now. So the message I would like to convey is deep vein thrombosis should never be missed. Again, I am taken back to my house NC days when we had a lady who was under our care. She was having renal failure. She developed swelling of the limb Probably adequate instructions were not given. She had suspected fracture. She was taken to the orthopedics department. Somebody tried to elicit the Holman sign. You know, the sign for thrombosis is passive dorsiflexion of the foot. If the patient develops pain in the calf muscles, the Holman sign is positive. That is conclusive of deep vein thrombosis. When we did a house NC, there was no ultrasound, there was no Doppler. We used to rely only on physical signs. But somebody tried to elicit this Holman sign, say dislodged her thrombus, went into the pulmonary vein. She developed a fatal pulmonary embolism and we lost her. You know that I never forget. So whenever I come across a DVT, I am very, very careful because I tell them, don't be ambulant, don't allow anybody to dorsiflex your foot. You should be very careful because now it appears to be very simple, a swelling of one side with pain, but then it can be dangerous as well. So it is very important that you diagnose a deep vein thrombosis. Now we are fortunate that we have gadgets like Doppler, CT angiogram, etc., which can clearly delineate a thrombus either in the deep vein or in the pulmonary vein, and we can institute appropriate treatment. Now, or if it's a non-pitting edema, usually it is a lymphatic obstruction. In the context of cellulitis, usually long-standing filariasis can produce a non-pitting edema. But when you see a lymphatic obstruction in the right upper limb, especially in a lady, you should carefully palpate the breast for a swelling or any history of mastectomy, where they also modified radical mastectomy. Also, they remove the lymphatics, which can produce a block in the lymphatic drainage and give rise to edema. What is the treatment? Prevention. You ask them to adequately exercise so the lymphatics develop and the fluid gets drained back into the lymphatics. And if you develop a lymphedema of the upper arm, it is very, very difficult to carry out your usual routine. A simple treatment like physiotherapy can prevent this disabling complication. Now let us see what the case scenario 2. This is the story of a 16-year-old male who is complaining of swelling of both eyes. So when somebody comes with swelling around eyes, first thing what you will ask is there any itching of the eye? Are the eyes congested? So probably it could be an allergic edema. If there is no allergic edema, if you don't think it's an allergic edema or angioedema, ask for swelling. Does it involve the feet or the abdomen? If the answer is yes, is there any history of hematuria? Answer is no. Is there any reduction in urine output? The answer is no. So 16-year-old male complaining of swelling of both eyes with no hematuria, no oliguria, no hypertension. And they then ask for history of vomiting, difficulty in breathing or headache. The answer is again no. So that means the person is not having any renal failure. On examination, the blood pressure is 120/80. So this 16-year-old gentleman or student has edema around the eyelids without hematuria, hypertension, and swelling of the feet, with the normal blood pressure of 120/80. The most probable cause is nephrotic syndrome. Again, the great teacher, Dr. Mani, used to say, he was the consultant nephrologist of Apollo Hospital. He used to say, when you say nephrotic syndrome, it is only just like saying it is fever. Somebody says fever, because fever doesn't give a diagnosis, you know. Fever, somebody is having fever, you have to investigate the causes for fever. So when you say this is nephrotic syndrome, the message conveys this: the person is excreting more than 3.5 gram per 1.73 meter square in 24 hours in urine. So it does not tell you anything more than that. So you have to carefully investigate the patient renal profile, which includes creatinine electrolytes, serum protein, albumin, lipid profile, urine culture, X-ray test, and ultrasonogram, and probably depending on the situation, you have to do a renal biopsy as well. Predominant treatment for nephrotic state is steroids. We are not going to the details. The topic is only edema. You have to exhibit additional immunosuppressants if required. So what is the cause of edema here? As we discussed earlier, here the edema is due to massive loss of protein in the urine, hypoalbuminemia, decreased plasma oncotic pressure, producing edema. So the dictum is whenever somebody has got an albumin of less than 2.5 gram, you have to bring up the albumin at least to about 2.5 by giving albumin infusion. You know, the problem with albumin infusion is stays in the circulation only for 48 hours. So there is no role for a routine albumin infusion. If the albumin is dangerously low, and if the person has got ascites also, then there is a threat of peritonitis or infection occurring. In that case, you have to correct with albumin. Now, what is the next problem? If the patient had said, I am passing cola-colored urine, or my physician told me you are excreting RBCs in the urine more than what is expected, my blood pressure is on the higher side, I have not passed urine more than 500 in the last 24 hours, the triad is satisfied, hematuria, hypertension, and oliguria. So the probable diagnosis here is acute nephritic syndrome. So acute nephritic syndrome is again only telling you it's an acute situation which has got its own sequelae and complications. We will be discussing separately. Again, the investigations are done: urine protein, 25-UMA protein, renal profile, albumin, lipid profile, culture, ultrasound, etc. But you should always exclude a secondary cause, infection-related glomerulonephritis, SLE, etc. And what is causing edema here? The cause of edema here is increased hydrostatic pressure due to sodium water retention. Again, if you remember the earlier slide, whenever there is an increased hydrostatic pressure that is pushing the fluid from the capillary, that activates the renin-angiotensin-aldosterone axis along with the ADH, which retains more sodium and water, that produces retention of fluid in the interstitium, and that produces edema. So here the treatment is not albumin. Here the treatment is salt and water restriction and the blood pressure control hypertension. Now let us move on to the third scenario. This is a 60-year-old male complaining of swelling of feet. He gives history of diabetes of 5 years duration, history of hypertension for which he is taking amlodipine. Is he ever told to have proteinuria? No. Does he have history of treatment for diabetic retinopathy? No. What is the urine show? What is the urine show? The urine protein is normal. There is no even microalbuminuria. What is the renal profile? Normal. What is serum albumin? Normal. So what is the probable cause? You should always remember amlodipine and certain other drugs can produce edema by vasodilatation. This is a very harmless thing. And the blood pressure is very well controlled with amlodipine. It is not necessary to change amlodipine for the edema. But our patients are very concerned. They will keep on telling you that no, edema is disturbing. Everybody comes and asks me, why are your legs swollen? So I would like to change that. Okay. So whenever you see edema in a hypertensive patient with no clues in the urine, biochemistry, etc., then you have to think the drug is the culprit, and the usual calcium channel blockers, more common with amlodipine, can produce this problem. If you don't get any drug also as a culprit, then you have to carefully evaluate the thyroid for hypothyroidism. So let us see this. What is the story of this 40-year-old alcoholic? There is a history of jaundice. He presents with distension of abdomen and edema of feet. So what are the leading questions you would like to ask? You know that this patient has got a liver disease. So you have to ask for history of fever, abdominal pain, diarrhea, or reduction in urine output. Then you call this as a pseudo-hepatorenal syndrome or a hepatorenal syndrome. He says no such history. Is a well-compensated liver disease. Is he jaundice? No. Investigations, urine routine, LFT, renal profile. Again, the investigation shows hypoalbuminemia. We all know that liver is the site of synthesis for albumin. And if the liver disease of more than 21 days duration, the synthesis of albumin gets affected and this produces hypoalbuminemia. This 70-year-old gentleman presents with difficulty in breathing and edema. History of chest pain, yes. Suggestive of coronary artery disease. History of hypertension, hypertensive left ventricular failure. Renal profile, investigation shows increased creatinine of 5 milligram. So what is the probable cause? This is a very dangerous situation. No? This patient has got coronary artery disease. He has got a left ventricular hypertrophy. His echocardiogram earlier showed only ejection factor of 40%. Added to that is the new problem now of a creatinine of 5 milligrams suggesting renal failure. He has not been restricting his fluid intake. So the probable cause here is acute pulmonary edema due to fluid overload and left ventricular failure. And the cause for edema in this situation is again increased hydrostatic pressure due to LVF and also due to renal failure. So depending on the situation, you have to assess the emergency. So what are the miscellaneous causes? Again, there are many ladies around 40, 45 coming to the OP and saying that there is edema of the feet, which is usually occurring the perimenopausal period and also the premenstrual time. You investigate extensively, you find no cause. The treatment is only reassurance. You have to tell them that this edema is not of any consequence. This is a normal thing which occurs in some ladies related to hormonal disturbance. And you have the only thing is a reassurance. There is no specific treatment. Beta blockers have been tried earlier, but not of convincing result. Hypothyroidism is a cause not to be missed. So when we see edema, what are the red flags? That is, what are the dangerous signs? If the edema of sudden onset, if there is a significant pain, if the patient is dyspneic, if the patient is febrile, if there is a history of abnormal cardiac examination, reduced ejection fraction, or earlier myocardial infarct, if the patient has got hemoptysis, dyspnea, or if evidence of pleurisy, if the patient has got evidence of liver disease, as ascites, splenomegaly, hematemesis, or there is an evidence of DVT, as said earlier, a unilateral leg swelling. These are some dangerous signs which demand your attention. So, to summarize the evaluation of edema, patients with generalized edema should undergo a urine routine. You have to look for an albumin creatinine ratio. You should look for microscopic hematuria, complete blood count, blood urea, creatinine, serum electrolytes, serum protein, essentially albumin, and LFT. The special investigations you do when you suspect a cardiac failure is a brain nitro-pro-BNP, brain natriuretic peptide. If you suspect pulmonary embolism, you have to do a D-dimer. Patients with isolated lower extremity swelling should undergo an ultrasonography and Doppler. So what is the treatment? In general, identify the specific cause and treat. The mainstay of treatment is on diet. You have to ask them to restrict sodium, which is very, very difficult for our patients, especially in patients with renal failure, who can't give them potassium chloride also. So there is no substitute. You have to only restrict your normal sodium chloride to less than 4 grams per day. If this patient has got a chronic liver disease and cirrhosis, the sodium restriction should be less than 1 gram, which is very, very difficult. Indian diet, normal salt intake is around 6 to 8 grams. Potassium salts available in Kerala as in Dupa should be substituted carefully because in patients with renal disease, it can produce hyperkalemia. In patients with normal renal function and the potassium is low normal, you can give potassium chloride because it's also useful for controlling hypertension. Also, make the diet palatable. In patients receiving potassium-sparing diuretics, angiotensin-converting enzyme inhibitors or blockers, and those with a kidney disorder, potassium salts may lead to fatal hyperkalemia. So you should be very careful when you advise them. Now, the current treatment that is coming to vogue is a sodium glucose co-transporter. SGLT2 inhibitor. What are the drugs available? Canagliflozin, dapagliflozin, and empagliflozin. What do they do in edema? It produces in diabetes, it excretes glucose in the urine, produces an osmotic diuresis. It also produces, along with osmotic diuresis, loss of sodium and water. So it can also produce reduction in edema. So it is currently it is emerging as a first line of treatment for diabetes mellitus, non-diabetic hip disease, non-diabetic heart disease as a prevention treatment. You can use the edema is severe and affecting the patient if they are tachypneic or there is a fluid in the lungs. We can use thiazides if the GFR is more than 30 ml. Loop diuretics like furosemide or torsemide if the GFR is less than 30 ml. You can add truxylmetazone. But the problem here is you have to carefully monitor for hypokalemia because they lose sodium and potassium. And whenever somebody loses potassium, hypokalemia, especially in liver disease, it can precipitate hepatic encephalopathy. If you use potassium sparing diuretics like aldactone, tramterine, etc., you have to monitor for hyperkalemia. So the best bet is to combine thiazides with potassium sparing diuretics if the renal function is relatively normal. What are the precautions in the elderly when drugs are used? You know, even small doses of drugs can produce problem. So you have to use your discretion because the patients may develop orthostatic hypotension, they may fall, they can develop a fracture. So when you use diuretics, AC inhibitors, beta blockers, clonidine, etc., along with loop diuretics, it can produce severe orthostatic hypotension, especially prazosin. So you should carefully monitor blood pressure in the lying down and the standing position up to 2 minutes. And each time the patient comes to PD, the elderly, you should make it a point to measure BP in the lying down and standing posture as well. You have to carefully look for hypokalemia and hyperkalemia. As I said earlier, somebody has got edema and you are sure it is due to calcium channel blockers. That is not indication. That's not an indication for stopping amlodipine. You have to reassure and convince them as in idiopathic edema. More than the urine output, the most reliable monitoring is by weight. You have to take weight in the same time, either the empty bladder or the full bladder, almost the same type of test that will tell you what is the progression of edema, whether the edema is decreasing or increasing. So in the last 35 to 40 minutes, what I have been trying to tell you was generalized edema, the common causes can be chronic liver disease, heart failure, renal disease. When there is a local cause for edema, venous obstruction, lymphatic obstruction, infection should be considered. Don't treat edema for cosmetic purpose. Acute onset edema, detailed evaluation is required. Treatment depends on the cause. To summarize, we went over the definition, classification, and pathophysiology of different types of edema. Case studies were presented to illustrate how to diagnose, investigate, and identify probable causes of different edema in patients with varied medical history. Thank you for your patient listening.